Just to give you a little bit of background, I've been a pediatric nurse for 24 years at the bedside, 12-hour shifts. If you would have asked me, as a young nurse, that I would be speaking publicly, doing policy, procedure, evidence-based practice, I would have been like, absolutely not. I'm going to stay with my patients and with my families at the bedside. When I met that survivor almost over a decade ago, I actually met that survivor when I was volunteering as a court-appointed special advocate. I did not learn about human trafficking through healthcare. I learned about it through volunteer work as a court-appointed special advocate through nonprofit groups. That meeting really inspired me to think, what can we do better? What can we do better in healthcare, not only to educate healthcare providers, but start identifying youth that we're coming into contact with. I'm not seeing my slides. Nope. Nope. Is anybody available to?
Yeah, we're working on it.
Okay. So if you look at where the intersection of healthcare and human trafficking is, that really, when you're dealing with healthcare providers in large medical institutions, you have to use evidence-based practice. Everybody wants to know, what does the peer-reviewed literature say? What is the prevalence? Back in 2014, there was a landmark study done by Letter et al., which showed up to 88% of people with lived experience had intersected with healthcare providers while being trafficked. That was very surprising to many of my colleagues as I began presenting on a national level, because they're like, wow, 88%? Are we seeing this? Are we experiencing patients who have had this lived experience but not identifying them? There's been other subsequent studies after that showing similar. McKinney, Chisholm, Straker et al. Did another study in 2016 where you can see up to 68% had interaction with healthcare providers, but it also showed the scope and the span of where people were seeing healthcare providers, not only in the emergency departments or in acute care, urgent cares, clinics, pediatricians, even dental visits. I have tons of slides with tons of data and so as I started going through, Well, I can just keep going. Yeah. So the other important thing too is they wanted the data, especially within my institution, of what are we seeing for prevalence here in Orange County. So if you look at our hospital charts and you ask them to pull how many are we seeing, biostatisticians would pull data and say how many are we seeing in our hospital. And it would look like zero because healthcare providers weren't using ICD-10 codes for diagnoses. People weren't documenting accurately in the chart, and being able to pull that information retrospectively was really difficult. The Orange County Human Trafficking Task Force puts out a report every 2 years. That was really beneficial for me within my own institution just to show the prevalence. Our last report from 2023 showed 420 survivors within our own county. 37% were youth under 18 years of age. That is very surprising to many in healthcare because of the amount of minors that we're seeing within healthcare and even within Orange County. Okay. Okay. It's just, I kind of want to give people the visual as I'm going through that. But anyway, that information really helped kind of push things forward, both from a medical institution perspective. Also, I wanted everything that I'm doing not only to be evidence-based in order to translate that into healthcare, but also to make sure that it was survivor-driven. It's not based on what I say as a pediatric nurse or what we're also seeing in literature or maybe from clinical experience, but what are survivors experiencing? What are their perspectives on healthcare and human trafficking? I conducted a study in Orange County on youth survivors and what their experiences were within healthcare, but also what can we do to improve that? Many were saying they were never asked those sensitive questions, and it was consistent with other studies and other literature. There was another qualitative study done with 51 participants, and they were saying 47% were never asked the sensitive questions. 23% reported not experiencing privacy within their healthcare experience in order to disclose that information. When you're talking to healthcare providers, that's like nursing or physician 101, providing privacy. But in that busy healthcare institution, if you don't have something to kind of help you navigate through those processes, sometimes it falls by the wayside. Within my own institution, really creating pillars to medical institution response, it's not just about awareness. You can educate providers on human trafficking, but if it's not updated, it's not accurate. I even, had a conversation, I was presenting last weekend, there was 194 nurses from women's health, obstetrics, and neonatal nursing. And I asked everybody, how many have heard about human trafficking? And of course, everybody raised their hands. And then I asked, how many have been trained on human trafficking, identification, screening, and response? And maybe 2 people. So there's huge gaps within that arena, even with healthcare providers. When you're looking at medical institutional response, you need accurate education. It also needs to be not only on human trafficking, but trauma-informed care. Many people are talking about trauma-informed care from a neurobiology standpoint. Healthcare providers can tell you what the neurobiology is, the effects on the brain, maybe how it affects coping ability, but how do you implement it? What are the implementation steps? I personally use the PAIR tool because it was validated for inpatient healthcare, and it also provides a quick step guide going through an acronym of providing privacy, educating, asking, respecting, and responding, meeting that person where they're at. Then, once everyone's educated within your institution, many providers are still not aware that there's multiple barriers, both from a provider side and a survivor side, to disclosure. Survivors feeling fear, shame, even fear of judgment from what they've experienced through other healthcare experiences. Survivors saying they felt, even though the provider was trying to help me, I reported multiple sexual partners, and they looked at me like they were kind of concerned, but they didn't push further. They didn't ask, are you involved in anything? Or on the flip side of that, feeling that they were judging them. They're like, as someone with lived experience, I'm really in tune to somebody's body language, the way they're looking at me. And if they looked at me with that face of disgust, I would immediately shut down. And I didn't want to share the rest of my experiences. Other youth that reported even having gunshot wounds, and nursing asking, what gang are you from? And she said, I was not involved in any gang because of my injury. Why are you thinking that I'm from a gang just because I have this type of injury? So really being able to educate healthcare providers on trauma-informed care, building a rapport, creating a space to kind of help with that disclosure, and then also screening. So there are validated tools for screening. There are not a plethora of them. There are limited, some are limited to sex trafficking. You want to make sure that you're using a comprehensive tool for your specific population. So if you're working with adults, you don't want to use maybe a tool that's used for 12 and up. If you're working with a pediatric population, you want to make sure that you're using a screening tool specific to pediatric populations, making sure that it's including sex trafficking, labor trafficking, as well as high-risk behaviors. There was a youth that had come in, diagnosed with an eating disorder, had a history of running away from home and then also Orangewood. She came in with a backpack with taser and condoms. She was admitted for an eating disorder. The physician, the first thing he said was, I knew that was a prostitution backpack. So already there's biases just based on that person entering with a taser in a backpack. A few days later, she disclosed to one of the nursing aides that she runs away to LA and exchanges sex for money and things of value. Now, many healthcare providers, without policy behind it, explaining legal definitions of what trafficking and exploitation look like, youth that are exchanging sex for something of value under 18, even though there's not a trafficker present, still falls under that definition. But there are still healthcare providers that are not aware of those definitions. So making sure you have a policy in place that's sustainable beyond any one person's employment at your institution, making sure that policy includes the legal definitions, having a patient response algorithm, making sure that you're using a screening tool validated for your specific facility and your population. I think that in my own practice was really important because there's still healthcare providers and we're so focused on making sure survivors have this comprehensive approach. There's very complex needs that are involved, especially with the healthcare impact of human trafficking and exploitation. But healthcare providers really want to do a better job. I've worked with healthcare providers, trauma surgeons, nurses, physicians saying, I knew I missed something, but I didn't know what to do. I didn't know what to do at that moment. If you look at data just from the pandemic, Polaris had put out information not only with the increase in online recruitment being 22%, increases in Facebook, Instagram, familial trafficking. A lot of those numbers are really surprising to some healthcare providers because they're not immune to the sensationalized imagery that they also see on the media and through movies. So really making sure that that data is accurate. Back in 2019, I had created this response algorithm for what to do. It's kind of like a decision tree. I based it on an asthma action plan because that is what I knew from my own practice. But that's really important because healthcare providers are super busy. They get caught up with either the diagnosis, what's happening on the unit. They need to be able to make those decisions accurately and knowing who to call at which point in that response. And then referral and resources. They're not going to stay at your facility, your clinic, or your hospital forever. It's having a list of resources so when they leave your facility, you're doing safe discharge planning. You're working with survivors to be able to identify what that looks like. Having a list, they said, even if it was on the back of a hand sanitizer or a little card, having that list of resources is important. And even for healthcare providers, many healthcare providers weren't aware of what was available even within their own community. Shelters, drop-in centers, victims assistance, how to do those referrals. So I think when you're looking at medical institution response, if you do get the opportunity, make sure that you do have a medical person with you that is aware of all these other steps that are involved, because if you bring up awareness or you're educating on human trafficking, if you don't have all the other pieces in play, it's still going to fall by the wayside and it's not going to be a sustainable response. So making sure that you have all of those things together in that package. When working with survivors as well, it's not a one and done. And many of those who are well versed in exploitation and human trafficking are aware of that. But healthcare providers that I've worked with, over the past 5 years are still not aware. It's not a one and done. It's really planting the seed, being able to provide comprehensive care. The healthcare impact, not only from mental health, PTSD, anxiety, depression, acute injuries, whether it's broken bones, lacerations, reproductive health issues. I think about chronic health conditions that many are not aware of. I think about kids with asthma, diabetes. One survivor diagnosed with diabetes at a young age was trafficked throughout her adolescence by a family member, was not identified through healthcare until later on. She's now in recovery. I've been to healthcare visits with her where providers were saying, yeah, we're not going to give you an insulin pump because you have a history of non-compliance. And that is something that's been reported by survivors either being called non-compliant or saying, I was what you call a frequent flyer. So, it breaks my heart because you hear these terms within healthcare, but to hear someone with lived experience use those terms when they're referring to themselves is heartbreaking because they really didn't get the services they need or have that seed planted that, yes, this is a safe space. We're here for you no matter at which point in recovery you're at. So this particular survivor, was being called non-compliant, not wanting to give the insulin pump, and then ending up on dialysis. And for me, that's not improving patient healthcare outcomes. If we really want to provide optimal patient outcomes, it's not just noticing red flags and risk factors, it's also asking these sensitive questions to all youth who are at risk. Being able to ask questions within the healthcare realm. I'm a nurse, so I have many youth that won't say anything to their parents, but the minute I ask teenage questions when the parents are outside the room, they spill. They open up and they tell me all kinds of things. But knowing what to do with that information and how to connect them with the resources they need upon discharge is really going to be key. How much? Okay? Okay, great. Thank you.